Welcome to the Physician Leaders Network, Patients Medical Home in Your Practice Part 2. In our first segment with Dr. LaRue, we shared some key messages on the what and the why of the Patients Medical Home model. And this segment will focus on describing some of the behaviors in primary care practice that lead to becoming more Patients Medical Home-like. We'll also be providing some examples and some practical tips to advance our thinking on Patients Medical Home. As mentioned, this is Mark Watt. I'm with the Alberta Medical Association and joined today by Dr. Jordan LaRue.
Hi there, I'm Jordan, family physician out of Sylvan Lake, Alberta. I have a couple other hats that I wear, some with the university in terms of training students and residents, as mentioned on the previous podcast or webinar. And I've also spent 4 years as a physician lead in the Wolf Creek PCN, and now transitioning out of that and into the Central Zone lead for primary care networks. And here to talk today a little bit about some of the practical experiences I've had in terms of our evolution and trying to become more patient medical home-like.
So as discussed in our first segment, the Safety Net Medical Home Initiative identified 8 implementation elements to progress towards becoming more Patients Medical Home-like. And importantly, they identified a particular order that is helpful to consider when looking at where to start. The first 2 implementation elements, engaged leadership and capacity for improvement, are grouped as laying the foundation. When we talk about the behaviors for engaged leadership that lead us towards Patients Medical Home, we see behaviors like visible and sustained leadership to achieve cultural change. We see behaviors around ensuring the team has enough resources to be successful with their changes. We see behaviors like protecting time for team members to conduct activities outside of patient care. And building Patients Medical Home values into hiring and training processes. When we think about the capacity for improvement element, we're talking about behaviors that are exhibited within the practice, like establishing and monitoring metrics to assess improvement, optimizing the use of technology to deliver proactive care, involving patients, providers, and team members as all active participants in quality improvement activities, and using quality improvement models and tools to help guide improvement to make improvement. Jordan, I'm wondering if you might be able to share an example of an important change within your practice that is helping you and your practice teams become more medical home-like.
Sure. The example I decided to come up with came from earlier on when I came into practice, but was certainly not the beginning of the journey of my clinic. A number of years ago, we decided that we needed a vision statement to focus our physicians and lead our team. We did a vision exercise and came out with a strong vision, which happens to be forge a path and change a life. Up until that point, we had general buy-in from all of our docs in what we were doing, but not until an actual dialogue happened like that did we have a clear vision to come forth that allowed the group to constantly move forward. In essence, the dialogue was just as important as the words on the page. The reason I chose this example is because I like a high-level focus on things, and to me, this was the beginning of my own buy-in and read ownership of evolving towards a patient's medical home.
So Jordan, it sounds like that was a very critical moment for your practice team, but was this a required step in being able to move your practice forward?
No, I personally believe there's lots of ways to skin a cat. There's lots of routes to getting to the patient's medical home, and you have to do what's right for you at the time. For ourselves, I really feel it was important at that time. We could have done everything since then without that vision statement and that, or vision agreement maybe. However, this allowed us to approach all of our challenges and roadblocks with a common vision in mind. And in times when we would have maybe each of us gone different ways about a subject, this brought us together down a common path. We still use this vision statement for very important decisions, and it's a very simple but powerful tool, mostly because of the conversations that were had that the vision still represents. So Mark, what tips would you have to share for the Physician Leaders Network?
So physicians across the province tell me that they are more successful implementing patient's medical home when they or another leader within their practice takes a team approach to setting practice goals and objectives. As you described, it's about having that dialogue. They talk about coming together as a team to really assess and plan what changes would be meaningful, and having that full buy-in that you previously referenced, and that when physicians or leaders provide a supportive work environment, so that the team can feel ownership and maximally contribute towards the vision, is really what they describe as some of the successful tips to moving this forward. In relation to capacity for improvement, again, physicians have shared what their recipe for success looks like. And it really includes things like aiming for improvement. So not trying to shoot for perfection, but also not being satisfied with the status quo. That they measure just enough to learn. This is not measurement for research, and this is not measurement for accountability. And to be able to advance patients' medical home, it's just about having just enough information to answer some questions. And that they try to make change through testing, which means they try it once in a very low risk environment, and then try it 5 times. And if it's promising, then try it 25 times to see if the results really do bear out.
Yeah, this certainly seems to ring true with the experience at my clinic with our group. Those small measured changes that are then sustained, keeping your risks small, and just do baby step it forward. For those of us who are What About Bob fans, it really does work.
Great. The next 2 implementation elements are around building relationships in patients' medical home, and they address the concepts around panel and continuity and team-based care elements. In Alberta, there has been a strong focus on these areas for the past couple of years. And while there's been great momentum generated with panel identification, the panel and continuity element is more than identification. It's about how do we use that information to plan to meet the needs of the patient panel, and how do we support that panel with a continuity of care across those 3 elements, relational, management, and informational. Also, in a patient's medical home, team-based care is evolved beyond having staff available to help you deliver care at the point of service. It's about having a care team, including members from the PCN or AHS, that are organized to provide and be accountable for all of the needs of the patient's panel. And that the care team and patient recognize each other as partners in care, and that is the experience that patients have. It's about access to the care team is provided whenever possible. This is not all relying upon the shoulders of physicians, and that all team members share in care provision tasks based upon skills and ability. So Jordan, thinking about your practice, and can you give us an example that articulates some of your progress around building relationships?
Sure. So certainly I came into my current practice, and with that practice already having a certain amount of this work underway, it actually was one of the major attractive elements of me trying to join that practice. It was a major reason that I joined it. I saw a team-based environment that was a bit different from other places where I'd worked as a resident and as a student. Everyone there had worked or was working to maximal scope. My MOA to my nurse to myself. I did those things that only I could do, and I minimized those things that my team would be able to do. For example, I was squeezing in a patient with a fractured ankle, a farmer who never presents to the clinic, right? And then the next day I got an ultrasound report on AAA screen, which my team member, my MOA, had opportunistically done prior to me seeing my patient. I had no effort in arranging that, but I was able to review that and other things that he was due for as well. Otherwise it wouldn't have been done. If it was reliant upon me, he may not have actually had that screening. that was pretty cool in and of itself, and I think there's nothing less cool than me saying cool. But the second part of this was how this model started to evolve even more once we began to pilot blended capitation. We had our PCN team members sort of wrapping care to a degree around patients, but I think as we all kind of remember from the Auditor General's report a number of years ago, that we're pretty much only funding around I don't know, thereabouts 30 or so % of what is actually required to create a robust primary care system. So there's only so much that we can do, though, even though that which we do we do well. But blended capitation allowed us to leverage that model to further increase our staffing, and we brought on more patients in the community that weren't seeing doctors. We brought them on, and through the blended capitation model, we leveraged that into additional team members such as an LPN, RN, and a clinical pharmacist, and we began to further increase the team that is wrapped around the patient for further access. And so I'm no longer that isolated person that provides care to the team members. They have, or to the patients, and they have an option of ways to access their care through myself, through my pharmacist, through my nursing staff, as is appropriate.
Wow, Jordan, it really sounds amazing how you've started to approach redesigning some of these team-based care. And really challenging status quo and looking at opportunities to be aspirational and moving towards your vision. Around the province, when we talk to physicians about panel and continuity, it appears that the critical behaviors that are exhibited are around a commitment to identifying that patient panel, that there is, again, specific behaviors around maintaining that panel list and confirming with patients at every opportunity, and that the team schedules visits with their primary care provider and allied team as they're able to, but with a strong focus towards that. The evidence around relational continuity of care is so strong that it is coming with very strong recommendations of, if this was the one thing that we could do in primary care, this would have the most significant impact on reducing death and morbidity and mortality for patients. And so there's an excellent article that we will be sharing with the Leaders Network.
Yeah, continuity is the next new drug. Except for it's going to work.
And additionally, tools like the Central Patient Attachment Registry and community information integration projects will help continue to advance this across our province. Jordan, do you have some tips that you might share around team-based care?
Sure. Some of the things that we learned, number one, regular meetings. When you stop meeting, things start to slide. I meet with my MOA daily. We have a quality improvement team that meets weekly or bi-weekly in the clinic. You reap the results of that, whether you realize it or not. What I mentioned earlier, it's like being on an escalator. You have to invest a little bit of that time, and that will always move you forward. We actually went through a period of time where our QI team had stopped meeting for various reasons, and even though we still kind of collected data during that time, we weren't really acting as much on it and weren't meeting about it. And then you can kind of see through the data, when we kind of got our act together again and revisited that, we saw how things started to slide. So we experienced that regression and even measured it. And so that kind of caused us to redouble our efforts and refocus to realize how important that is. And I mean, if you're not getting value out of your meetings, you look at you redesign your meetings, right? I mean, the meetings have to achieve a purpose. You don't meet just for the sake of meeting. You have to achieve what works for you and what you need to achieve through those meetings. You have your discussions, not just about the work itself, but how to actually improve the work and move it forward. Again, the baby steps. Asking questions like, what should we do more of? What should we do less of? And I'm a huge believer in this, looking for every opportunity to co-locate your team members. It improves the teamwork, and it's worth the effort to optimize. We have maximal co-location of our primary care network team members. We have started and are exploring further even co-location of our Alberta Health team members, starting off with mental health. And that was a huge silo to break into. Of all the AHS services, it seems like it was more siloed than the rest. And having a mental health liaison in our clinic has really helped break that down, and how it's changed the attitude and the interaction. Again, how we can work together towards the patient has been completely worth it.
The next set of medical home implementation elements are around patient-centered interactions and organized evidence-based care. The behaviors that we're talking about for changing care delivery include using planned care templates according to patients' needs, identifying those patients who are at high risk and ensuring that they're receiving appropriate care or case management services, enabling point-of-care reminders based upon the evidence-based clinical guidelines, and enabling planned interactions with patients and ensuring that all of their information is up to date and available to providers at the time of the visit, and so they're not having to go searching or finding during the encounter. Behaviors are also things like respect for patient and family values and their expressed needs, that we encourage patients to continually expand their role in decision making and in their self-management. That we have expectations around communicating with patients in a culturally appropriate manner, in a language and at a level that the patient understands, and that we have behaviors around self-management support is being provided at every visit, and goal setting and action planning is normal. Obtaining feedback from patients and family about their healthcare experience, and then using this information as provided to help guide continued practice improvements. Jordan, I know that your team has been thinking about this a lot. Can you share an example from your practice?
Yeah, sure. So one of the ways that we're having patients engage differently in their health is leveraging the patient portal on our electronic medical record. The patients I've seen have started to have interest in their results, and they ask questions differently using that mechanism than they would in a normal clinic visit. If you think about it, how many people come to the clinic while they're potentially quite ill or not at their best, and they perform their best when they're trying to engage you about their health? I mean, think about the power differential, if nothing else. Some people deal very well in that situation, others not so much. However, they can follow up on their results after the visit with you, and they can consider things and chew on them, and they can come up with more thoughtful questions. Or even better, they can actually review the results prior to the visit with yourself and come better prepared to get more out of their actual visit with you. I found that to be quite huge. They can process things a bit before the conversation. The other thing that another example, we've implemented engaging our patients in our care delivery. We've just started to scratch the surface here, and one initiative we did was a patient questionnaire. I found this actually a bit uncomfortable because, I mean, there's some worry about opening up about how we do things and saying, well, did you want to comment on that? And how can we use that comment on how we change what we do? Honestly, I felt pretty vulnerable, and there was a big fear, like, would the patient act entitled? How much would I have to cater to what very well could be a needy patient or unreasonable demands? I mean, I'm busy enough, and I feel there's enough demands on my time. But you know, we still went through with it.
So Jordan, I mean, when you talk about that, I mean, some of the questions that I hear talking to physicians is that, you know, are you talking about treating patients like consumers or customers?
Yeah, you know, a little bit of that. I've always actually had a natural aversion to doing that, because I feel, I don't know, there's a bit of romanticism in terms of being, physician. There's a call to service, and I've kind of aligned with that a little bit. And the idea of customers and whatnot, and the first knee-jerk reactions, I didn't want to be treated like a vending machine, and I wanted to be treated like a person with values and a way to engage with my patient. Having said that, after going through this process now, I was impressed with the thoughtfulness and the engagement of the patients. My fears about how they might treat me were kind of unfounded. They weren't over demanding or this or that, and they wanted to be engaged, and they had some really good ideas for how their insight was, and I learned some things. And I humbly learned some things. So I think I kind of came to a more evolved position where you can't throw the baby out with the bathwater. I recognize now the vulnerability that I had to go through and I had to accept, but also that this brought us to a better understanding of the system by seeing the world through their eyes.
Oh, it sounds like you're being very courageous and thoughtful in your approach to moving forward with Patients Medical Home.
Here are $20, Mark.
So again, when we talk with physician leaders about patient-centered interactions, the types of tips that they provide us are primarily around working with the PCN to identify programs, resources that would support your practice team. We see that we communicate and choose tools and resources at a level that the patient understands, and that we get feedback from patients and family about their experience, which I think you've already very eloquently discussed. In relation to organized evidence-based care, some of the really meaningful things that physicians have engaged with are things like obtaining their Health Quality Council panel report and looking at those for opportunities to improve the clinical services that they deliver. We know that many PCNs offer specific clinical services and programs that are aligned around delivery of better quality clinical service delivery, or provincial programs such as Alberta Screening and Prevention are all really simple, practical ways to start to implement organized evidence-based care. The last pair of implementation elements are around reducing barriers to change. And these speak to the concepts around enhanced access and care coordination, with some of the specific behaviors in practice being reflected by promoting and expanding access to the primary care team so that there is coordination towards a 24/7 access with the appropriate mechanisms in place. And that patients are provided scheduling options that are patient and family centered and accessible. Behaviors like linking patients with community resources and facilitate referrals and respond to the social services needs. That we integrate behavioral health and specialty care into to the care delivery through optimizing our co-location or standardizing and communicating our referral protocols. Behaviors that track and support patients when they obtain services outside of the practice, and that primary care practices follow up with patients within a few days of an emergency room visit or a hospital discharge, and communicate test results and plans of care with patients and families. So, Jordan, can you share again a little bit of insight in terms of how you've been trying to tackle this in your practice?
So I guess in our practice, I'll talk about leveraging our EMR and the way that patients access myself or my team members. It's about facilitating our patients to be able to access their care team in the right way, at the right time, and with the right person. So this could actually mean phoning in for an appointment for the nurse, or booking online with my pharmacist, or messaging your doc for a non-urgent question or a refill. All of those are kind of mix mash of how people can actually access their team. I guess once again there was a bit of vulnerability in trying to give up control of how my patients accessed me and as well as access the system. Very fearful of like, okay, well, I'll allow my patients to message me, and then what kind of dam will that break down, and what flood will unleash, and will I be able to handle that? But once again, I feel that after the fact, a lot of my fears were unfounded, and this was extremely well received by the patients, but also us as providers. It's very satisfying to provide care in a way that makes sense. For example, by a phone call or by an email or secure messaging, instead of being forced to do all of the work through an office visit. I think in addition to that, you were talking about linking patients to community resources, and I have to say that one of the things that is completely necessary and seems to be increasingly complex now is helping our patients navigate their referrals and also their transitions of care. Transitions of care is a very critical time in a patient's healthcare. I mean, it's the place where things can go wrong more easily than other times. So it's a big focus of what our central zone is going to try and accomplish and smooth out in the next year or so. But I can't. Again, we're dealing with people who are not necessarily at the top of their game. If they're accessing the healthcare system, that's usually because things are not awesome. So having my staff to follow up on referrals for them and to help navigate them and connect them to their referrals, sometimes where we're referring them is excellent in terms of coordinating this. Other times they're not as excellent, and they may only have 3 hours in a week where you can actually call and try and get a hold of them, but they won't return your phone calls, don't leave a message. So I found that it's absolutely crucial in trying to connect our patients or to have that services to connect our patients to the appropriate referrals. It's much more so than just writing off a referral letter. In addition to that, we have one of our nurses that we can always, or a team of nurses that we can go to. So when I get notification of admission or discharge, I flag that to my nurse. And so she keeps an eye out for when they are discharged, or when they are discharged, trying to get them in within the week to at least say, how are you doing? What was the plan? Going through the discharge summary, assuming I got that. What medications are you on? And just because they got a prescription and the discharge doc dictated that all nicely in a letter, now that it has twice as many medications, and they can be confused. Do you understand your medications? Is home care coming to see you? Were they supposed to come see you? Has that been missed? There's so many things that can fall through the cracks, and we can keep these patients in their home and in their community if we help facilitate that and smooth out that transition process.
Well, thanks, Jordan. In addition to that, I've also learned, a very important new medical diagnosis: not doing awesome.
It's very common.
So thinking about what other physicians have told us about enhanced access, and in the province we've had a history with things like AIM collaboratives to help tackle things like issues around access. And what we see in terms of behaviors or a recipe that seems to be, to show some promise are things like committing to do today's work today, seeing your own patients and not introducing any unnecessary waits for them, leverage the full care team and the PCN supports to look at different ways of providing access to a broader care team. Shifting your services and the types of services in order to meet the demands of your particular panel. And of course, measure just enough to learn, measuring specifically around, what are the demands of the panel, that your panel has, and how does that impact with the supply to your care team that is available to meet that? Is there anything here that really sticks out for you, Jordan?
All of them, like those are really critical. Like those little mantras I'd probably just put up around the office. Commit to doing today's work today. I have to say this might be my personal journey, where I am in my career, or it could be the journey of my clinic, in terms of going from fee for service to blended capitation. But I found that really became more feasible for me and more desirable when I moved from fee for service into a blended capitation model, where I almost felt like I had more capacity to pull today's work into today. and that might be the incentive and disincentives that are built into the blended capitation model too. But I realized it as a truism prior to that, and I'm starting to change and work like that, and that's actually pretty cool. Yeah, I'll leave it at that.
Yeah.
I know where we're at for time, so.
And I think you've really, in your examples, you've really spoke to the value around care coordination, and specifically, I think in your examples you were talking about having dedicated resources and expectations with particular staff members who can coordinate referrals and facilitate those transitions of care, and that you develop relationships and opportunities to develop agreements with how transitions will be managed with different specialist groups and different programs and community agencies.
Yeah, I think I ranted about this a little bit early, so that was for this slide.
And I guess the last thing that I hear, and I'd be interested in your comments, are around spending some time and energy to standardize the information that you provide other specialist providers in helping them be able to meet their needs for information. And have you made progress in that way in your clinic?
No, but that's okay. We've actually had those discussions. In particular, for us, to be around some orthopedic referrals, for various other reasons. But we have had those chats about what kind of information can we put in there and make sure is done before we actually send that off, just to ensure we're advocating appropriately for our patients and they get triaged in an appropriate fashion. So those discussions have happened, though we haven't actually acted on that yet. And that's just where we're at in our journey, and it just wasn't a priority at this time.
Well, thank you so much, Jordan, for sharing, really where you're at with some of your transformation efforts in your practice. I know some of them, maybe seem very aspirational, and I think that's great that you can share, where you may be on the cutting edge, as well as some of the places where you haven't necessarily spent time to focus yet. And I think that really speaks to what the patient's medical home journey and transformation is about, is this commitment to learning, commitment to sharing, and the continued progress towards those values and ideals. I guess in closing, I just wanted to remind people that this is provided by the Physician Leaders Network in partnership between the Alberta Medical Association, Alberta Health Services, the Alberta College of Family Physicians. We look forward to having you join us for segment 3, where we will discuss what supports are available for practice teams to advance on their primary care journey. Thank you.
Thanks, Mark.